So, how do drugs act in the body? Well, they can alter how a cell functions. You have bronchitis during the winter, a nurse practitioner is going to order an antibiotic for you because he or she has determined that you have also have a bacterial infection. The antibiotic is either going to kill the bacteria outright or stop it from replicating so your own immune system takes care of it. Now, receptor binding, we're going to talk about how drugs bind to cell receptors and create an action. So if you have gastroesophageal reflux disease, heartburn, for example, I'm going to give you a drug like omeprazole, which is going to stop that production, lower that production of gastric acid. It binds to cell receptors. Antacids, this is where you need to make the change. Antacids don't bind to cell receptors, although sometimes they call omeprazole an antacid, but it's not a true antacid. Antacids actually neutralize the acid. It works right on the acid in your stomach. So I want you to understand the difference between receptor binding and something that acts right on a fluid in your body. Okay? So you're going to see these terms. You're going to see agonist. You need that explained again?
Yeah,
okay.
Yeah, sorry.
The medications that we give can act directly on cells like antibiotics, antiviral agents. Most of the medications we're going to talk about actually work on cell receptors. And I'll give you an example later on. It's going to bind to a receptor in the cell and stop the cell from functioning. There are other drugs that affect fluid in the body, like hydrochloric acid. They're going to neutralize it. That's what an antacid is. Sometimes they call meds like omeprazole, which binds to a cell receptor, they call that an antacid. But a true antacid is like Mylanta, something like that. Does that make more sense? So we're either going to affect the cell by killing it or stopping it from replicating. We're going to bind to receptors in the cell to stop the cell from producing gastric acid, whatever it is. Constricting blood vessels, when we talk about cardiac drugs and antihypertensives. Or there's a third thing, we're actually going to act like a chemical in the body. If your patient is in shock, for example, you're going to give them soda bicarbonate. It neutralizes acid in the body.
So it's a third.
It's a third thing.
Oh, I was just gonna say, couldn't like receptor binding, like think of it like how aspirin or Coumadin does, because aspirin will bind.
Yes, by the platelets, right. Yep. Perfect example. Okay, now you're going to see this terminology. An agonist is something that helps the body's natural action. And I've given you an example here. If you get injured, your body will release endorphins. Endorphins are natural pain relievers. You come to the emergency room, we're going to give you morphine that's going to also be a pain reliever. It acts with those endorphins to relieve pain. It's an agonist, it helps. Antagonist is just the opposite. It reverses the action of a medication. Giving you an example here of Narcan. If somebody takes too much morphine, they're going to become too sedated, respiratory rate's going to drop. We have to reverse that. We have to antagonize the effect of that morphine. So we give them Narcan. Teratogenic, these are drugs that harm a developing fetus. We're really concerned about the first 3 months of fetal development because that's when organs are being developed. But there are some drugs that we'll learn about that can affect a developing fetus right up until the time of delivery. Drug tolerance means that your body has gotten used to the chemical and we need to give you more of it in order to produce that beneficial effect. Drug tolerance is not addiction. We're gonna talk about addiction in a couple of weeks. Drug tolerance just means your body is used to that chemical that we're putting in it, and we need to give you more in order to get the reaction that we want. Well, it's usually a drug that we give you, and some people can take one Tylenol, acetaminophen, and get relief of their headache. Other people need two. It's just how their body reacts.
Like after you take Tylenol for so long, it just doesn't do it anymore for you, so you either need to switch or have to go.
Right, well, if you take it on a daily basis, yes. Yeah. So we're going to talk about onset, peak. Something for the chemistry department, which usually once this semester we'll have to shut down the school because they've spilled something up there.
That happened to
Yeah. That's why they don't let me near any of those chemicals, because I would be the one to spill something. Can't even walk on the floor. Okay. Terminology, onset. How long does it take for this chemical that we put in your body to actually create the effect that we're hoping for? The minimum effective serum concentration is the lowest level of drug in your body that will produce that desirable effect. Peak is the highest concentration of drug in your bloodstream. Now make sure on the learning module you look at peak and trough. That handout that I put on there. As a nurse, you will have to draw blood levels of some medications to find their peak and their trough. Trough is the lowest level. The lowest level usually occurs right before the next dose. But you will have to draw a peak level and a trough level, mainly of antibiotics. We do it for some other drugs, but antibiotics are the big ones. Loading dose. We're going to talk about binding sites, nonspecific binding sites in a minute. We need for that drug to be in your bloodstream so it can go to the cells it needs to go to and exert the effect that we want. When we first put a chemical in your body, it goes to nonspecific binding sites that act like magnets and hold on to that chemical. Protein and fat are those two nonspecific binding sites. Once those binding sites are filled up, then the next dose of drug we give you is able to go out into your bloodstream and get to the cell that we need it to go to. And we'll talk about that a little bit more. So in a loading dose, we're going to admit the patient to the hospital, and we're going to give them the usual dose of medication, but on a very rapid schedule. So we might give them that usual once-a-day dose every 6 hours, because we're trying to fill up those binding sites. Now we have to monitor that patient because they can become toxic because we're giving them so much medication. Does that make sense? We're going to talk about one drug in a couple of weeks, lanoxin or digoxin. It's to help regulate the rhythm of the heart. So we want that to get into the bloodstream rapidly so that we can get them out of what we call atrial fibrillation. Yeah. There aren't many drugs that we do that for, but there are some. A Z-Pak. If you have bronchitis and you go to the nurse practitioner and he orders a Z-Pak for you, you get a large dose the first tablet that you take. Why? Because we're trying to fill up those binding sites. Therapeutic range is the range between when it's helpful and when it's toxic. There are about 4 meds we're going to talk about, or 5 all year, that have a therapeutic range that you have to memorize. And I'll tell you what those drugs are. Okay, you're all going into gerontology for clinical. Most of you will be on a rehab unit. These are well elders who maybe have had a heart attack, they've had surgery, they've had a hip replacement. We only keep people, nitrogen, yes, just go right out the door. We only keep people in acute care for about 72 hours now. They can come in with 6 health deviations. Once we stabilize the reason why they came in, they're out the door. I have rheumatoid arthritis in my hip. I need a hip replacement. Go to surgery, they replace the hip, 72 hours, I'm gone. They send me to a rehab unit. That's where you'll be for gerontology. The patients, most of them will be 65 years of age or older. Look at how many medications they routinely take. Now, these patients, when they're home, took between 4 and 6 meds a day. That can be over-the-counter things, too. I take Tylenol because I have arthritis. I take an aspirin as an anticoagulant. Maybe I take a couple other meds prescribed by a physician. So there's a 50-50 chance that you're going to see side effects. But look what happens in the people you're going to be taking care of. We've upped that medication now. The more different chemicals you put in your body each day, the greater the risk of a side effect. Now, it doesn't mean that it's life-threatening. We're going to talk about the side effects that your patients are likely to experience. You're going to monitor them for cardiovascular effects. Many of them are on more than one different class of antihypertensive med. So, when you stand them up, their blood pressure can drop, they get lightheaded, and they faint. So with your patients, you want to sit them up on the side of the bed, wait about 5 minutes, standing there talking to them, and then stand them up. If I tell you the first 10 people out either door get an automatic A for the class and you never have to come to class, you would jump over tables to get out the door, right? I might make it out before you do, who knows? You're young. When you get up, the smooth muscle around your blood vessel constricts, so you still get blood going to the brain. You don't get lightheaded. You may get trampled, but you're not going to get lightheaded, right? Your elderly patients, that smooth muscle doesn't react as quickly, so when you get them up, their blood vessels stay expanded, blood pools in their legs, doesn't get enough to their brain, and they faint. So always get them up slowly. Watch for central nervous system effects. They may become confused. They may start to hallucinate. They may become very sedated. Just because you have a patient over the age of 60 doesn't mean that they're all confused and that they all have dementia. There are drugs that we give to stop them from developing a stress ulcer that will cause them to become confused and hallucinate. So always check, is that their baseline? If it's not, confusion is not normal. Gastrointestinal. Virtually all meds will cause nausea, vomiting, diarrhea, or constipation. You have your choice. So we have to deal with those side effects so that patients continue to eat and empty their bowels regularly. Integumentary, a rash. Sometimes patients develop a rash from a medication. Now, a rash can be the sign of a drug allergy. The very first time we put that chemical in their body, they will not have an allergic reaction to it. Why? Because their immune system first has to identify it as something harmful, even though it is not. The second dose forward, they can have an allergic reaction. So, somebody can take penicillin when they're 15 years old. We put that chemical in their body. No reaction. They go in for surgery when they're 35. We give them penicillin. The very first time you infuse that penicillin, they go into shock. Now, if they never had that penicillin when they were 15, and you gave it to them the very first dose at 35, no reaction. You're working the next day, you give them another dose of penicillin, that's when they can go into shock. Or they can go into shock after the 100th dose. The concept here is, once a chemical has been introduced in the body, the immune system may decide it's harmful, and so the next time it encounters it, they go into shock. So we're going to watch for rash, we're going to watch for hives, we're going to watch for difficulty breathing. Nausea and vomiting are signs of an allergic reaction. It's the beginning signs. If it's not picked up, they can go into shock. Right? So if someone has had a reaction, they may not have gone into anaphylactic shock, but maybe they've developed hives. They need to wear a MediAlert bracelet or carry a MediAlert item.
You suppose allergic reactions happen, like it doesn't have to happen on the second dose, it can happen, like, say, at the 100th dose?
Yeah, we don't know. We just don't know. It may never happen. But the takeaway point here is you always assess your patients, especially when you're giving antibiotics, because that's the class of meds that causes most allergic reactions, but it can happen with any medication. You're going to find that some drugs are ordered at certain times of the day. That's because of our circadian rhythm. We're trying to support normal body functioning. So if I'm going to give you prednisone because you have bronchitis, I'm going to tell you to take that prednisone in the morning. Why? Because your body produces cortisol in the morning. So we're enhancing what the adrenal glands are normally releasing. On the other hand, if you have high cholesterol, and I'm going to give you a drug to lower your cholesterol, I'm going to tell you to take it in the evening. Why? Because your liver produces most cholesterol in the evening. I'm going to do the same thing with montelukast, which is a leukotriene inhibitor, which you'll learn about in a few weeks. It will help prevent an asthma attack. Why? Because it's most likely to happen at night, so I'm going to give you that montelukast in the evening. So the takeaway point here is, if a prescriber says, take this drug in the evening or take it in the morning, explain to your patient why. Right, so they get the most benefit from the medication. So a client has started on an anti-infective they have never received before. When should you plan to monitor for an anaphylactic reaction? Anytime, second dose onward. Now, that doesn't mean the second dose that the nurse gave while they were in the hospital. You have to find out, has the patient ever taken this medication before? Right? Takeaway point here is chemical goes into the body once, that's when we may become sensitized to it.
So do we say 90% that after the first dose, nothing's going to happen?
It will not happen after the first, it will not happen when you give the first dose, right? Because the body has to say, oh, this is not supposed to be here. I'm going to mount a reaction if I ever encounter this again. But that first dose could have been 10 years ago.
Can't there be a small anaphylactic reaction, like lips tingling or something, and the next time you have it, your throat fully closes?
Some people have the same type of reaction to a med each time. There's no such thing as a mild allergy because we don't know when it's going to escalate. So some person may be exposed to peanuts, they're allergic to peanuts, and they get a little rash. We don't, and every time they have something with peanuts, they get a rash. We don't know if that 10th time that they are exposed to peanuts, if it's going to escalate into full-blown anaphylaxis. So there's no, you hear people say, I have a mild allergy. No, you have an allergy. You're lucky that it hasn't been more than a rash, but it could be.
How does the circadian rhythm, does it change with like shift workers?
No, we have found that the best thing to do if you like to work nights, 11 to 7, is just work nights. Don't rotate. Nights, evenings, nights, days. Stay on nights. I guess after a number of years, your body might get used to it, but you will notice that when you're on your off days, you sleep when people normally sleep.
Okay.
Yeah.
So you would still take your anti-cholesterol
Yes.
in the evening? Or?
Yeah. Because it's not the fact of lying down that makes it, it's just sleep-wake cycle.
Gotcha.
And on those days off, especially if you work 12-hour shifts, you have 4 days off.
Yeah.
You go back to the usual, how people who don't work nights sleep. Okay, we're going to talk about kinetic and dynamic action. We're going to talk about each one of these in turn. So kinetics means movement. Dynamic is how drugs interact with each other. So in kinetics, we're going to talk about absorption, distribution, metabolism, and excretion or elimination. So when we talk about absorption, we put a chemical into your body, and say we're giving it to you orally, the pill has to break down, and it has to be absorbed through the mucosa in order to get where we want it to go. Distribution means that the bloodstream carries it to the site of action. So let's talk about oral drugs because most drugs are given orally. It's going to cross that mucosal lining of your GI tract. And how quickly it passes can depend on pH. The pH will change whether or not you take it on an empty stomach or with a meal. So another reason, if the medication is supposed to be taken on an empty stomach, make sure the patient takes it on an empty stomach. If it's supposed to be taken with food, make sure it's taken with food. And explain to your patients why. Your upper intestine absorbs, that's where the absorption into the bloodstream, most of the drugs takes place. So if you have an intestinal disease, it's going to affect how easily that drug is absorbed so it can be distributed. Now, when you're under extreme stress, when you're in pain, the brain says to the blood vessels feeding the GI tract, okay, constrict, we can't deal with anybody eating food right now. We have to shunt this blood to the heart. Because you're under stress, your blood vessels constrict, the heart's having a harder time to pump. We need to support the heart, not the stomach. So when a patient takes an oral medication, it's going to be absorbed much more slowly. If you have a high-fat meal, it delays emptying into the small intestine, so you're not going to get that absorption. So these things can all impact on how quickly a drug is absorbed. If you don't have good circulation, if your heart is failing as a pump, your blood vessels are constricted, you're not going to be able to get that drug that's been absorbed circulating around to get to the site it needs to go to. Okay, so now you have a nurse, and the nurse has administered albuterol. It's an inhaler. Patient has asthma. The absorption of the medication, how long do you think it will take for that inhaled medication to be absorbed? And it is very rapid because your lungs are well supported by the circulatory system, so they inhale that medication, it goes right into the bloodstream. It doesn't make any difference if the bronchus is constricted partially. This medication is going to open up the airways, cause those muscles to relax. But we have so many blood vessels in the lung, of course, that it's going to be absorbed very, very quickly. Now, we're giving a lot of medications now through patches called transdermal. So if you give medication in a patch, or you put it under the person's tongue, or you put it in their lip, between their cheek and their gum, or you put it in an inhaler, these meds go directly into the bloodstream. They do not pass the liver first. So we're going to talk about the effect of first pass effect. So if you're giving it transdermal, you're giving it under the tongue, you're giving it in the cheek, or you're giving it inhaled, it's absorbed rapidly and it goes right to the site of action.
Is that the medication that we give sublingual or by color is more effective or more quickly?
It acts much more quickly, because it doesn't have to go by the stomach, pill be dissolved, get absorbed, go through the liver. We're going to talk about what happens when drugs first go through the liver. So it's very rapid action. If it's given through the skin, under the tongue, inhaled.
Is it the same thing with IV?
Yes, IVs, it's immediate. Yep. Okay, now we all have plasma protein. We all have adipose tissue. These are called non-specific binding sites. When we first put that chemical in our body, these non-specific binding sites are like magnets, and they hold on to that chemical. Then they slowly release that chemical. It is only when the chemical is released into the bloodstream that it can be active. Think of these chairs as non-specific binding sites. You're glued to these chairs for 3 hours Tuesday morning. Who was cruel enough to do that, right? You are not active. Once the class is over, you are released from your chairs to go out and be active.
Can you put it down when it becomes active? As you said at first, when it's released.
Say that again.
Can you put it down when it becomes active?
Toxic?
Active.
Active when it's released. You're not active right now.
No, I understand that part, but just the first thing that you said.
Yeah. The non-specific binding sites are either fat or protein.
Yeah.
Okay? So some chemicals have an affinity for fat. Those chemicals will react to that fat magnet and fold it. Some have an affinity for protein. You all have protein circulating in our bloodstream. Boom, it hooks onto it. And then it slowly releases it. It's not till it's released that it's active. Does that make sense to everybody?
Is that on purpose?
Yes. Well, that's just how the drug acts. So that's what they discover in that preclinical development phase.
And is that with all medication?
All medication.
That's my question. I
Yeah.
don't and it goes straight to the receptor?
If we give it IV, because it's already in the bloodstream, it's gonna go right to the site of action. See, when it's hooked to fat or protein, even though the protein is in the bloodstream, it still is this magnet. It has to be released into the bloodstream before it can get to your brain cell, your bone cell, wherever it's going. So when that magnet effect is taking effect, it's not active. It's in your body, it's not giving us the effect. It's only when it's released. And it all gets released in a predetermined amount of time. That's why we give some medications once a day. That's why we give some medications every 4 hours. How quickly is it released? How long does the action take? We'll talk about that a little bit more. Now you can have two drugs, two chemicals that want to hook on to the same protein binding site. Some have a strong attraction for that protein magnet. Others have a weak attraction. Think about if I get what's that game where you played where they play music and you had to sit in a chair?
Musical chairs.
Musical chairs, all right. Everybody played musical chairs at one time in their life?
Yeah.
Okay. So I've got chairs set up here. And we're gonna play musical chairs with 5 of you and 5 kindergarten students. And you're told if you can sit in that chair, automatic A. Right? You're gonna be like glued to that chair. Right? So we start the little kindergarten students are faster than you are. So start the music and a little kindergarten student sits in the chair. You come off and boom, you knock that kid off. My chair. Right? You have a stronger affinity for that chair than the kindergarten student. How the molecules act in your body. Now remember, when is a drug considered active? When it's sitting on that chair or when it's released?
When it's released.
Okay, so I give you a drug that is weakly protein bound. It's hooked onto that magnet, but it's not very tight, but it's hooked on. And then we give another drug that is strongly protein bound. That strong protein bound drug is going to do what to the weaker one?
Kick them out.
Kick it off. When it kicks it off, that drug now is circulating in the bloodstream. So the takeaway point here is, if a new drug is added to what the patient takes, watch for adverse effects from the drugs. You cannot memorize, nor is it your responsibility to memorize, which is a highly bound protein drug, which is not. You're just going to watch for how the patient reacts now that this new drug has been given. Because if we gave a strong protein drug and we had a weak one before, that weak one is circulating in the bloodstream and exerting more of an effect. Does that make sense?
So it's like giving double medication. It's like
Well, we could get more of an effect than we are expecting. Because more of one drug is now in the bloodstream.
so the patient will find out more.
Yes. For example, I'm going to give you an example in a second. In fact, let me do this. Okay, aspirin and Coumadin or warfarin are both anticoagulants, but they act in different ways. So, Aspirin has a stronger affinity. It kicks Coumadin off, so there's more Coumadin now floating in the bloodstream. Now the patient may have too much Coumadin in their bloodstream. Coumadin is one of the drugs that we have to get lab values for and keep the patient in a certain range. All right, so patients in the hospital, they've had a brain attack caused by a blood clot. So the nurse practitioner says to the patient, we're going to send you home on warfarin, which is generic Coumadin. Okay. Patient goes home, and we stabilize the patient. We do blood work every day to make sure the dose that we've ordered is in that range. Great. Patient goes home. They watch TV, and what do you see every 30 seconds on TV? Take aspirin. Oh, gee, it prevents heart attacks, stroke. Oh, maybe I should take that. They go down to Stop and Shop, and they pick up aspirin. Do they tell anybody? No, because it's not a medication. It's in Stop and Shop. So now we get their blood work back, and their Coumadin levels through the roof. What happened? They still don't tell us that they're taking aspirin because it's not a medication. Tell your patients, if you start taking any medication that you buy in over the counter, please call your healthcare prescriber. Because now we've got a patient who could hemorrhage because of too high a dose of Coumadin. So does that make sense now? Mm-hmm. Weight and basal metabolic rate can affect how quickly drugs are metabolized and eliminated. So if you have a patient who's very fluffy and we give a highly adipose-bound drug to that patient, right? They've got a lot of binding sites. So they're going to have a lot of chemical hooked on to that adipose tissue by that magnet. It's going to be released slowly. So even if we stop that medication, they don't need it anymore, they're going to have a long duration of action, right? Because they've got to have a lot of binding sites, it's going to be released slowly. Basal metabolic rate, the faster we metabolize or break down a medication, the faster we eliminate it. So that patient may need more frequent dosing. That's up to the healthcare prescriber. Now, sometimes your patients are malnourished. They do not have a serum albumin level that's within the reference range. They have too little albumin in their bloodstream. And I've given you things that can cause this. They may have malnutrition. They may have intestinal disease where they can't absorb that protein from their food. They may have liver disease. Your liver makes albumin. If they have cirrhosis or hepatitis, they're not making as much as they should. They may have kidney disease. When albumin circulates through the kidneys say, oh, we want to keep this. We don't want to spill it in the urine. But if they're in chronic renal failure, their kidneys aren't responding well and they're just dumping the albumin. If they've had severe burns, a third-degree burn, they're losing plasma proteins because their skin is gone. So all of these things can give them a low albumin level. Now, if you give a drug that is highly protein bound, and they have a low serum albumin, what's going to happen to most of that chemical? Where is it going to be? In the bloodstream or hooked on to protein?
What's
In the bloodstream, which means it's active, right? So the healthcare prescriber is going to have to adjust the dosage.
Going back, I'm sorry, one slide to the whole weight, if you have a heavier person, would you give them a higher dose?
They will, if they have a drug that's highly bound to fat cells, they will have action from that drug later than somebody who's lean, because we've got to fill up those sites.
So what do you do?
See, we don't want to give them a real high dose, because once all those sites are filled up, we don't want them to be toxic. It may take them 48 hours before we see an effect from the drug, as opposed to 24 hours. The thing that's going to happen is once we stop that drug, they're going to have a long duration of action because it's releasing it slowly. Okay, so here's an example of cell drug receptors. Okay, so we take the drug, pills dissolve, it's absorbed, it's distributed, it hooks on to fat or it hooks on to albumin, it's slowly released. Once it's released, it goes to cell receptors. It activates that cell. Sometimes you're going to learn about drugs that we give that actually block those receptors so the cell does not act as it should. Remember, we're trying to change the function of the cell. But the drug has to be active. It has to be in the bloodstream before it can do that. So I've given you an example here of tamoxifen. If a woman has breast cancer or a man has breast cancer, we are going to see if their tumor is estrogen receptive, meaning in the presence of estrogen, it causes that tumor cell to grow. Now, men also produce estrogen just like women, but in a lower amount. Just like women produce testosterone like men, but in a lower amount. So breast cancer affects both men and women. If it is an estrogen positive receptor tumor, meaning estrogen in the body acts like fuel thrown on a fire. It makes those cells proliferate. We're going to give tamoxifen that blocks those receptors so that estrogen has no effect on cancer cell growth. Does that make sense? Okay. So that's an example of what we do with receptors. Here we're blocking it. Many of the chemicals that we give actually activate that cell to do something else. Right. Now we've got duration of action. How long does that chemical produce that effect in the body? And it differs according to what chemical we're giving people. So, if you give a medication once a day, does it have a long or a short duration of action? Long, right? You're giving it every 4 hours, long or short? Yeah. Okay. Now, we can exert that chemical effect by having that chemical bind to receptors, or it can, as I said earlier, actually affect chemicals in the body. Your patient goes into shock, the pH is going to lower, we're going to give them soda bicarb. It acts on the acid in the body. Okay, so which med has the longest binding capacity? One taken once a day. It binds to adipose tissue or plasma protein. It's a strong binder. It's released slowly so that chemical remains active in the body for a full day. Now, distribution, again, means the blood carries that chemical to the cells it needs to carry it to. We have what we call a blood-brain barrier that prevents most chemicals from crossing over into the brain. That's the reason why it's very difficult to treat brain cancer, because we've got that barrier that prevents that chemical from going across. We're going to talk about other drugs throughout the semester that are difficult to cross that blood-brain barrier. So a client is receiving antibiotic treatment for a wound abscess. The nurse recognizes that distribution to the abscess requires what? We have to have adequate blood distribution. And we can't get the medication into the abscess. Biotransformation or metabolism means we either make the drug inactive or we make it more active. Some drugs we have to make water soluble. So liver is the place where most, 99% of the metabolism takes place. The kidneys, the organ that eliminates most of the drugs. Right? So the chemicals are going to exert their effect and then we flush them out of the body through the kidneys. Now in your liver, you have enzymes. These enzymes metabolize or inactivate most medication. You do not have to remember the families, the isoenzymes. I just want you to have seen how we name these hepatic enzymes, because you're going to see them mentioned in your book. You do not need to memorize this information. I want you to understand where it comes from. These are enzymes in the liver that are responsible for metabolizing medication. Now here comes our friend grapefruit juice. Grapefruit, either grapefruit or grapefruit juice, will inhibit one of these enzymes. If the drug is not metabolized or broken down, it remains active. Does that make sense? Mm-hmm. So, your patients, if they say, I drink grapefruit juice every day, that's great. If they say, I don't drink, because you're going to ask them, I don't drink grapefruit juice at all, that's great. They just have to tell their healthcare prescriber if they start eating grapefruit or drinking grapefruit juice, or if they stop. because the dosage of the medication may need to be changed. Now, if I drink 3 glasses of grapefruit juice a day, and I take a medication that is acted on by the enzyme that grapefruit juice affects, am I going to need more or less dose of that medication? Less, right? Because I don't have the enzyme that's going to break it down because I'm drinking all of this grapefruit juice. It stops that enzyme from inactivating that chemical. I moved to Montana where it's cold. I don't want to drink grapefruit juice anymore. I had to tell my healthcare prescriber. Right, so they don't have to stop, or they don't have to stop. They just have to let the healthcare prescriber know. Now, it is impossible for you to memorize which drugs are affected by grapefruit juice and which are not. It's a waste of brain space. You can't do it. The pharmacist will alert patients, and you may see it on the inserts that you get with medication. Do not drink grapefruit juice while taking this medication. There's more information on the module.
Is it just grapefruit juice, or is gonna extend it to orange juice?
It's
or
not
citrus?
regular oranges like Sunkist, but you're gonna find, I'm not gonna give it away, you're gonna find when you read that thing, other citrus that can have the same action. Okay, so I've given you another example here of a drug, phenobarbital, that we use to prevent seizures, that actually stimulates the release of the enzyme that breaks down most medication. So, patient was on drug A, B, C, we had them stabilized, they're fine. Nurse practitioner orders drug D, phenobarbital. Phenobarbital makes the liver release more of that enzyme that breaks down medication. Again, you are not going to memorize which drugs make the liver release more isoenzyme. You're just going to make sure, you're going to monitor your patient every time a new drug is given, that they are still getting a therapeutic effect from the original drugs. That's the concept. Now, some people have a genetic variation in the type of isoenzymes produced. Remember, those metabolize or break down medication. So we're doing a lot of genetic testing now because your inheritance of genes may make you create more enzyme or less. That's the way that research is going now. Age. Premature babies are newborns. Their liver functioning is not up to what it will be as an adult. In elders, our liver function starts to decline. And if you have hepatitis or cirrhosis and your liver is damaged, you of course cannot create these isoenzymes. So all of these things can impact how you metabolize a drug. As drugs circulate through the liver, that's where the enzymes metabolize them. If you give a drug IV, there's very little metabolism of those drugs because they miss what we call that first pass effect. That first time going through the liver is where most of the metabolism takes place. So, you give it IV, your patient's in pain, 2 milligrams of morphine IV, their pain is now manageable. If you give the drug orally, goes into the intestine drain, the blood system drains into the liver metabolizes most of that morphine. So you have to give 10 milligrams by mouth to get the same effect as 2 milligrams IV. Does that make sense? Because IV, it doesn't go to the liver, it goes boom. Let's get right into the central nervous system here and help decrease pain sensation. Orally, it goes through that liver as the first time through the liver effect, and those isoenzymes go boom, 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 and blow those chemicals apart. So we need, now it doesn't metabolize 100%, but we have to give a higher dose orally than we give IV. Make sense? Okay. The nurse explains that a drug's half-life is the time it takes to do what?
Okay.
Half-life means how long does it take for 50% of that drug to be taken out of the bloodstream. Some drugs have a long half-life, some have a short half-life. Again, you do not need to memorize half-life, although you're going to see it in books like this that you're going to take to clinical. It's going to give you a lot of information that's nice to know, but you do not need. One of the things is half-life. If you become a nurse practitioner, then you need to know. But you're not going to memorize it. You've always got a book that you can look it up, because it determines how frequently we're going to give that medication. If I'm giving a drug that has a long half-life, do I need to give that drug every 4 hours?
No.
No. So, short half-life, more frequent dosing. Because remember, we're trying to keep the blood level of the active drug pretty stable. Now, if I have kidney disease, say I'm in stage 4 renal failure and I'm on dialysis, am I able to eliminate that active drug? No, it just keeps circulating and circulating and circulating. So the book may say the half-life is 4 hours. For me, I will not be able to eliminate that drug till I have my dialysis treatment. Make sense? It's still in there. It's very important that we try to give medications on time, because what we're trying to do is keep that blood level stable. There are certain drugs that you will learn about that must be given on time. Anti-HIV drugs, immunosuppressants after a solid organ transplant. Okay, you have a 5-patient assignment. You're about to prepare meds. The nurse comes running, the patient just fainted, fell on the floor, and hit their head. You've got somebody else who's throwing up. You've got a family member saying, can you get my father a blanket? You've got the unit secretary calling you saying you're getting a new admission in 20 minutes. I mean, okay, forget it, I'm going to have another career here. Can you get your 9 o'clock meds out to all your patients at 9 o'clock?
No.
No. Do not tell interventions I said this. Just line them up. Here, which ones do you want taken? You have to be realistic. Now, there are going to be good days. Nobody throws up, nobody faints, nobody's feeling wants anything, you don't get any admissions. Woo, I get all of my 9 o'clock meds out by 9:30. Woohoo! Cherish those days, right? They're beginning to lengthen the time. It used to be a half hour before, a half hour after. Is your hospital, has it gone to an hour before? An hour before, an hour, because they're being realistic. But there are some meds that must be given on time. Anti-HIV meds that prevent a solid organ transplant from rejection. So do the best you can. Do you think when your patients go home, they sit there with a stopwatch and exactly 9 o'clock they take their meds? No. Well, maybe 10:30, maybe 7. But you have to teach them, you know, it's best to take your meds on schedule so we maintain that steady state. Okay, get up and run around. Up, run around, 5 minutes.